Welcome to Pregnant in the Netherlands, your guide to pregnancy, birth, and beyond. I'm Julianna, a birth doula and a childbirth educator.
And I'm Anna, a doula, childbirth educator, and lactation counselor. We're here to support you with evidence-based information and honest conversations that help you feel confident, informed, and empowered throughout your pregnancy, birth, and postpartum journey in the Netherlands.
Hey, good morning, Anna.
Good morning.
And Happy New Year.
Happy New Year to you too. Happy New Year to all of our listeners.
We are finally back with a new topic. But before that, how was your trip to Turkey?
It was really nice. Yeah. It's the first time that we've been back in 15 years, and some things have changed, but a lot less than I think we had anticipated. And it was just really nice to have some of the food that we loved eating when we lived there. And
where?
we got to do. I lived in Istanbul.
Mhm.
My husband and I actually met there in Istanbul.
Lovely.
But we also visited Cappadocia and got to do the hot air balloon ride, which was really neat.
Oh.
Yeah. So it was a lot of fun just kind of taking our kids around, doing some of the things that we loved when we lived there, like riding the ferry across the Bosphorus and just eating really good food and things like that.
And it's so special to bring your kids there where you met and bring up all the memories.
Yeah, exactly. Yeah.
Yeah.
How was your holiday? You went to Hungary.
Yes, we went to Hungary. A lot of eating.
Nice.
And that's it. No, we also did nice things. We went to ice skating. And we spent a lot of time with my family. We were at my sister's. It was just one point when I was happy that my family don't speak Dutch, when my son said, "Why do they have such a strange food all the time?"
Oh, no.
And when my daughter chose broccoli soup, then I thought, okay, this is really not the food that they prefer. But then, yeah, at the point when you prefer broccoli soup above anything. But I think it's time to jump into our topic for today.
Let's do it.
Yeah, we've been planning it for a long time. Because first when we planned it, I think then you were unwell, you were ill that day. And then we planned it for the next week when I was actually at labor supporting a mama. And then we had to postpone it again. And then it's quickly New Year.
And here we are. We're going to jump in and talk about the perineum and tearing.
Yes. Do you want to start with the pelvic floor?
Sure. So in your pelvis, you have a bunch of muscles that are known as the pelvic floor. And these muscles help keep all of your organs and your abdomen, your baby up.
And holding your uterus.
Yeah, holding your uterus up. So that's on the inside. They help control like peeing, having a bowel movement, and also making space for baby as baby makes their way through the birth canal. And then on the outside, we have the perineum, which is the skin between the vagina and the rectum. And this skin includes the vaginal opening or the birth canal opening. And today's topic is all about tearing. So what can happen as the baby descends through the birth canal and begins to crown, the perineal skin begins to stretch. And if the baby is born maybe a little too fast, then the stretching can happen so quickly that it begins to tear a little bit.
And of course, that's the natural tearing. Mm-hmm. And then there's also the episiotomy. There is there's a cut made in that area. So I've never seen a cut downwards towards the rectum.
Yeah.
But more like in an angle of 45%.
Yeah, I think now the episiotomy angle is, yeah, you're right, a 45-degree angle between
I said percent, but I meant degree.
No worries. 45-degree angle downward, but not directly towards the rectum,
Yes.
a little bit angled away from that.
And it happens when you're likely to tear because, for example, vacuum is needed according to
Yeah.
your healthcare provider. And when your baby needs to be born quickly due to baby stress, for example, if they are monitoring the heartbeat and they see that the heartbeat is going way down and it's not recovering, or going up and not recovering, so that can be the moment. And before you have it, before they actually cut, you will have an injection of a local anesthetic into the
Mm-hmm.
muscle to numb that area. And then you will have stitches afterwards. But they
Mm-hmm.
often use dissolving, how do you call it?
Oh, yeah, the sutures.
Sutures,
Mm-hmm.
dissolving sutures to stitch it.
Mm-hmm. So then you don't need to have the stitches removed or the sutures
Yeah, yeah.
removed.
I attended a centering pregnancy group once where a clinical midwife attended, and we talked about episiotomy and interventions a lot. And afterwards, I also had a chat with her, and I went more into it. And she was at one point, I'm not sure if she was a bit annoyed by my questions, or it was like, she said, "Believe me, we are not cutting anyone for fun." And I thought, yeah, of course, I know that. But how is it
Mm-hmm.
possible then that there's such a huge difference in rates between the countries when
Yeah.
you compare, for example, Sweden and Norway, where it's like 6-7%
Of episiotomy, right?
episiotomy? I thought that you would
Yeah.
jump on 6-7, but you don't.
Oh, yeah, my kids would definitely
Would have.
go crazy right now. Yeah, so I think when it comes to episiotomy, I think that it was kind of it began as a kind of standard practice a while
Mhm.
ago. Um,
Maybe that it started at one point because it was thought or said that it makes the job of the mother easier. And then, oh, you are tearing anyway, so then why don't we just cut? And then it's easier to stitch.
a straight line,
Um,
yeah, yeah,
yeah.
exactly.
And then that birth can be quicker. And then they thought that it's better for the baby to be born
Hmm.
as quick as possible.
Hmm. But
Yeah.
then after lots of research and once women's experiences were
Yeah.
began to be shared after having an episiotomy and years of recovery from it, then they began to realize that an episiotomy can sometimes nerves can be cut and it can lead to either more painful sex or loss of sensation in the perineal area.
Yeah. And it
And
really, when it comes to recovery, moms usually just do better with natural tears than
exactly,
with
yeah,
episiotomy.
yeah.
And also, I think the psychological reason is that when it's torn naturally, you somehow process it better than when there was a cut.
Healing tearing happens along the natural kind of fault lines of the skin and possibly the muscle, and so it leads to better healing because it happens along these naturally weak points that
Yeah.
then can come back together and heal stronger, whereas an episiotomy, though it is a nice straight line that's easier to stitch up, um, on the internally, it doesn't quite uh, heal as well. And maybe at this point, we take a moment to define different degrees of tearing.
Yes, that's a good idea. First degree is a small tear of the skin and the vaginal lining, and it doesn't necessarily need stitches. It's usually up to the midwife. I had clients who were like, no, I want it to be just to recover naturally. I don't want any stitches. But then they can still say, okay, maybe it's nicer if I do just 1 or 2 stitches and it will heal better. And second
Mm-hmm.
degree, a deeper tear that involves skin and muscle of the perineum.
Mm-hmm.
And this is the most common type. And then the episiotomy is typically rated and treated as a second degree tear. But what can happen is sometimes it tears further. And
Yeah.
third degree is more severe when the skin and the muscle of your perineum and
The anal sphincter.
sphincter muscle, that is the muscle that controls your anus. And stitches are definitely needed in this case. And the fourth degree is the most severe one, extends to the lining, to the anus or rectum, and requires surgical repair.
So these third and fourth degree tears, these are considered severe tears,
Yeah.
and can lead to a painful recovery and possibly need some extra support in recovery with the pelvic floor muscles and things like that from a pelvic floor physiotherapist. So you kind of mentioned that one of the biggest risk factors for having a third or fourth degree tear is an episiotomy.
Yes.
The episiotomy can be cut, but then more pressure can be applied to the area as the baby is being born, and the tear can grow larger after the cut. Think of like if you were to rip a piece of paper a little bit and then pull on both sides, it's going to rip even
See
further.
further in that point or that line. Yeah.
Yeah.
And it's not
exactly.
only the fact that you get the episiotomy, but also in the position. More than likely, you are on your back in that moment when
Mhm.
the episiotomy. I don't think there is any other way how they do it.
Yeah.
So that also doesn't help, and the position itself.
Yeah, that's a really good point. That your birthing position can affect your degree of tearing, your risk for a higher degree of tear, and probably one of the most common positions that are related to a higher degree of tearing is on the back
Hmm.
with your legs up in a lithotomy position.
Yeah, it doesn't mean that you necessarily tear when you're on your back. Um,
Exactly.
just my last client who gave birth in the hospital on her back after being in labor for 30 hours, she didn't have any tearing, which was amazing. Like I
It is
really
amazing. Yeah.
didn't expect that, which I didn't know that when you are a really long time in the active phase of labor, then you also have a higher chance of tearing.
Mm.
And
Mhm.
she was definitely for a long time.
So maybe we can flip it around and say, what are some things that you can do during uh, labor and birth to help reduce your risk
Yeah, to
of
take
tearing?
care of your perineum.
Yeah.
Yeah. Sounds much nicer. It was so
Yes.
depressing, pretty depressing to talk about tearing.
Yeah.
Yes. So the position you mentioned already.
What are some good positions?
Like I think the best position is really whatever you feel is the best position. If
Yeah.
you have the if you feel so safe and if you have the support to just choose the position which feels nice in the moment, so that no one is telling you how you should give
Mm-hmm.
birth, but you just feel it. And it can be on your back, it can be whatever position
Mm-hmm.
feels right. And instinctively, you often feel it. What would be
Mm-hmm.
the best for the baby also to engage completely?
Yeah. Yeah. And if you have an epidural and you don't quite feel um, the urge, or the feeling is dampened because of the epidural, then I would encourage people to push on their side
Hmm.
rather than laying on their back.
What happens often, especially when you have epidural, that the care provider would like to see first what is happening while you are pushing. So they ask you at least for 2, 3 contractions to try to push on your back. That's my experience, at least. And then
Yep.
afterwards, they would let you turn. Like the last client I mentioned, she had an epidural and she had to start on her back. But then afterwards, she was free to go on on all fours. And then she
Mm-hmm.
tried like that again. And she could even
Nice.
turn on the side and go back on her back. And I said eventually she gave birth on her back, because, yeah, it was taking somewhat longer. And the clinical midwife said that I can coach you better if you're on your back. so then I can help you better.
Yeah. And that kind of comes down to their training. The clinical midwives and the gynecologists, they are trained to have the best visualization of the perineum when the client or the patient is on their back.
Hmm.
Whereas on their hands and knees, you still have a fantastic view of the perineum. Everything is just upside down.
Yeah.
Um, yeah.
But speaking of taking care of the perineum, um, she got anesthetic in her
Mm-hmm.
perineum.
Mm-hmm.
And I think that helped her relax the muscles there
Mm.
completely. I'm not sure if that was the key to not having any tear.
Hmm. Oh, interesting. I don't know that I've if that's very standard or very common. Maybe because her labor was so long that
Yeah, and
she needed
then she was
that kind
pushing
of help.
at that point already for an hour. And then
Mm-hmm.
in the moment when she got the injection, it got much better, and then the head appeared, and it was going really
Mm-hmm.
smooth. So maybe, yeah,
So that I mean, I think that we can tie that to something that can help with tearing is practicing relaxation,
yes,
and possibly doing a perineal massage. Not necessarily because the perineal massage stretches out the skin and the perineum. There's conflicting evidence about
yeah,
perineal massages during pregnancy, but it helps the client almost like psychologically get used to having stretching in the perineum, and being able to relax through that stretching.
100%,
So
yes.
it's a really good time to practice it because this is a very new sensation for most of us where we don't have really large things coming out of the vagina stretching it.
Hmm.
So being able to practice relaxing your pelvic floor muscles and breathing through the tension can really help prepare for
Hmm.
the pushing phase of birth.
I tried to do the perineal massage, but
Mhm.
then it felt so unnatural and so even painful. I thought, what am I doing here? I don't want this. But then what I did instead, I was really checking, when is that area relaxed? How can I
Mhm.
really relax my muscles and
Mhm.
learn that?
Yes, and what helped you make that connection?
I think yeah, that was already after my first baby was born that I went to a pelvic floor therapist, and she
Mhm.
told me that most women have no problems with, like, we are really strong down there because we have
Oh,
a
yeah.
lot of stiffness and we are doing CrossFit and running and jumping and those kind of things. So
Yeah.
it's contrary to the common view on it that we are that you're too soft. Opposite to that, it's that
Mhm.
you are too
Yeah.
stiff and cannot really relax the muscles.
Mhm.
And then she taught me that when I'm breathing, when I'm exhaling, then you should really feel how it feels, the muscles. And then often when you think, okay, I completely relaxed my muscles in the perineum, then you don't. And then you exhale and feel and relax. And then, okay, now you can really feel the difference.
The pelvic floor muscles they move together with your diaphragm. So breathing actually helps engage and also relax the pelvic floor muscles. So as you were saying, women hold a lot of tension in their pelvic floor, from being strong from running and CrossFit and all, but then also psychological tension. We tend to
Yeah.
hold it in our pelvic floor, to help protect ourselves.
Yes.
And so in my classes, I always like to say strengthening your pelvic floor is great. So that's doing things like contracting or doing your Kegel exercises to contract and strengthen it. But what's probably even more important in your birth prep is relaxing it. And then also, so softening it and then also lengthening it.
Mhm.
So, softening to do that, as you mentioned, taking deep belly breaths. As you inhale, your pelvic floor also relaxes. So, as your diaphragm moves down, your pelvic floor relaxes and moves down too. And then, as you exhale, then your pelvic floor moves with that. So, taking really deep breaths. It's a little bit hard when you're pregnant and you have a baby in your belly, but trying to breathe as deeply as you can and focusing all of your relaxation, focusing your thoughts to your pelvic floor muscles
Mm-hmm.
and really letting go. And then the other thing that I like to do is lengthen the pelvic floor, and that's doing deep squats and kind of holding a deep squat for a little while to help lengthen it.
It's really nice to mention it because I wanted to share something when I went to the Dancing for Birth workshop with Katja
Mm-hmm.
Krankina.
Mm-hmm.
During her workshop, she also gave a good tip. Check the distance between the vaginal opening and the anus in different positions. And simply in your undies, measuring tape, whatever, use or just a piece of rope or whatever. And then you can see the difference, and the difference can be really huge if you're in a deep squat. For me, that was the longest distance in
Mm-hmm.
between. Then you can also see how much space you give to your baby actually
Mm-hmm.
when you give
Yeah,
birth, which position
definitely.
give space.
Yeah. Yeah.
What is also important that the jaw, shoulders are connected to the areas down. So when you
Mm-hmm.
have relaxed face and relaxed shoulders, drop your shoulders. That helps also to relax your pelvis.
Yeah. And also feeling safe. Like I mentioned, we hold tension in our pelvic floor. And if you are holding tension during birth because you don't feel safe, it's just going to be so much harder to relax it. So surrounding yourself with people with your birth team that you can really trust and really feel like you can let go and be vulnerable and feel like you can be held during birth is
Mhm.
really important.
Yeah, and knowing that tearing is not a failure.
Mm-hmm.
And it's definitely not an end goal to avoid tearing.
Yeah.
It's more the goal is to take care of yourself, to let the tension go,
Mm-hmm.
concentrate on relaxing. And indeed, you can do it when you feel safe, when you
Yeah.
have the perfect support team around you.
Yeah. One other thing that I wanted to mention about reducing your risk of tearing is pushing in the water, laboring in the water.
Hmm.
Uh, and giving birth in the water can reduce your risk of tearing as well,
Yes.
which is fantastic because here in the Netherlands, you can have access to a birth pool, not just at home, but also in many of the hospitals.
We can talk about hands on and hands off approach.
Mm-hmm.
A hands off approach is when no one is touching you except you. When you feel some tension, you can protect your own perineum. That's what I often suggest to my clients. If you feel okay with that, if you feel comfortable with that, then check it, because then it can also give you a huge motivation boost, like, oh, I feel already some hair, or there's the head coming.
Yeah, it is such a motivator that like, oh, I'm pushing and pushing and I don't feel a lot of difference and I don't feel like anything is happening. And then when you touch your baby's head, you're like, oh
That-
no, actually I am.
that's what
I'm
I'm
I'm doing
doing.
some really amazing work.
Yeah. And then the hands-on approach is when usually the midwife helps you with a warm cloth against your perineum, or what I've seen also that they use the hand glove and fill it with
Mhm.
hot water, and it cools
Mhm.
down slower than the regular cloth. What also can help is a massage oil, really
Mhm.
natural, without perfume, baby massage oil, for example, and just apply it on that area regularly.
Yeah, so the midwife would apply some lubricant or
Yeah.
massage oil and gently massage the perineum to help increase the flexibility and the stretching of the skin,
Yes.
along with the warm compress.
Do you have experience with peri ball?
I don't, but personally, I don't think that encouraging people to buy extra devices and things like that is necessary to having a satisfying birth.
Yeah, I also have the same opinion. I had a client who did use it. She already used it for her first birth and she thought, okay, that was working, so I'm going to do it again. And it's fine if you want to,
Mm-hmm.
but I also wouldn't encourage anyone to have an extra device.
Mm-hmm.
Yeah, it's just a device that helps with actually the same thing when you are massaging your perineum, but then you have a sort of ball on the inside, a balloon rather. You can do some exercises to stretch the perineum. I think from week 37 you can really, yeah, you can use it.
Yeah. Yeah. And again, if you are choosing to use it, it's probably more useful psychologically to help you practice relaxing while there's something inside your vagina and
Yeah,
inside your perineum, something large and uncomfortable that's stretching the area, the tissue.
that's really true. You learn how to relax your muscles there, but I think
Hmm.
also there is a placebo effect that you believe in it and then it will
Yeah.
be effective.
Yeah, yeah, exactly. So we're not saying go out and get this device at all, but we're also saying if you already have the device and you want to use it,
Do it.
there's probably no harm in it. Is there anything else that we want to say about tearing?
Yes, I started about joking about the percentage in Sweden and Denmark that it was really low, but I also
Yeah.
wanted to mention that in the Netherlands, although it's, I have to say there are not a lot of data, not no clear resources and researches about this, which is really sad.
Mm-hmm.
But what I've noticed in primary care, midwifery care, if you have that, and there is a overall lower risk of episiotomy. It's 10
That's your
point.
midwife if you were to give birth at home or give birth in the hospital as an outpatient, unmedicated,
Yes,
low risk birth
with your own midwife.
with your own midwife.
And then it was 10.8% according to one of the data, I think from
Mm-hmm.
the
For we're
Groningen
talking
University.
episiotomy rates.
Episiotomy, yes,
Mm-hmm.
yeah, according to data from Groningen University, it was, I think, or yeah,
Mm-hmm.
one of the university researches. For the first time moms, it's higher usually. It was 20.9%. And the second time or more time moms, 6.3%.
Mm-hmm.
And there was
And
also research during the COVID era. Reports said that more home births were there and lower episiotomy rates, obviously,
mm,
because there were more like midwife led home birth settings.
mhm.
And then in the hospital in the Netherlands, there was a recent registry data showed that episiotomy in about 1 in 4 first time vaginal births and
Mhm.
1 in 10 later births.
Okay. Okay. So that's yeah, about 25% ish episiotomy rate.
Yeah, which is pretty high if you compare it to
Yeah.
Sweden and
And
other.
even compared to the US.
Yeah, yeah,
So in addition to practicing relaxation during your pregnancy and following your urge to push in the position of your choice, preferably not on your back unless it feels really good to you. Then also choosing a provider that has a lower episiotomy rate.
yeah,
So, like a primary care midwife, or a home birth midwife, or your own midwife. They tend to have lower rates.
yeah. In the in the article I just mentioned the rates from, it says the most important contributor to episiotomy practice found in our study was the vision of care providers on childbirth and episiotomy.
Yeah, so that just kind of supports that the primary care midwife has a more, they believe in physiological, they see physiological, normal physiological birth.
Yes.
And so they don't see their role as one that needs to intervene and cut and episiotomy.
Mhm.
So, Juliana, do you have any last thoughts about tearing or the perineum?
I do. To summarize it all, Nuni is a Hungarian word for vagina. So, what is the best for your Nuni? According to the statistics, staying at home as long as possible, trusting your body with your partner, midwife, and doula, possibly, and just listen to your body, push when you feel the urge, in the position you want, and don't rush the process. Learn to relax your Nuni muscles. Okay, bye for now. Viva la Nuni!
Viva la Nuni!